We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Pinnacle News Series in association with Akola, Alwar, Bagalpur, Bidar and Madurai Society. So let us start the webinar with Saraswati Vandana. It's my privilege to introduce the moderator of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant in reproductive medicine in Salem and national coordinator for Midlife Management Committee, FOXY. I welcome you, ma'am, and I hand the session to you.
Yeah, she's the master of ceremony. Welcome, Madhu. Over to you.
Thank you. Thank you. So, respected faculty and delegates, it's my very warm privilege to introduce you to this webinar, which is organized by none other than Professor Dr. Sampath Kumari ma'am. She is the professor and HOD at Sri Muthukumar Medical College at Chennai. She is a past vice president of FOXY, the Senate member of Tamil Nadu Dr. MGR Medical University, national corresponding editor of JOGI, and she's also the founder secretary of the Tamil Nadu Federation of Obstetrics and Gynecology, and she's also the current president of OGSI and the retired deputy director of Institute of Obstetrics and Gynecology at Madras Medical College, Chennai, current president of Board of Studies of TN Dr. MGR Medical University, and she was a past chairperson of FOXY Adolescent Health Committee, and she received the first ICOG Distinguished General Council Member Award. And she's also the chairperson of Women's Wing of IMA Chennai South and IMA National President Award she's received, and also the IMA Tamil Nadu State Branch Award. So over to you, ma'am, for the welcome address.
Yes. Well, thank you, Dr. Madhu and Priya. This is a Pinnacle News Series. As Madhumita told, we are gathering societies from North, East, West and South for the knowledge. So that is this is our Pinnacle News of 23rd series. Today we have Akola Society and Alwar Society, Bahalpur, Bidar and Madurai Society. I welcome Dr. Rajesh Modi and Dr. Ankush and Dr. Wish from Akola Society, and Dr. Abba and Dr. Charu from Alwar Society, President and Secretary, and Dr. Bida and Dr. Varsha from Bahalpur Society, President and Secretary, and Dr. Bidar Society, Dr. Uma and Dr. Savita, and Madurai, our own Madurai Society, Dr. Gayatri and Dr. Sudha. We have two sessions, one session being the PPH, which will be delivered later, and now we have the panel on induction of labor, which will be moderated by Dr. Nandita Thakur, and the expert being Dr. Richa Gupta, and we have the wonderful panelists Dr. Jyotsana, Dr. Nandini, Dr. Mangala, Dr. Priya Kanapan, Dr. Divya, Dr. Preeti, Dr. Sadhana Devi, Dr. Komadi, and Dr. Vijay Lakshmi. And I welcome our MOC, who is always, she will never tell no to anyone. welcome Dr. Madhumita and Dr. Priya. Both of them are wonderful moderators for this Pinnacle series. Without wasting time, we will first go with the felicitations. First, we will go with the Akola Society President, Dr. Rajesh Modi. Is he there?
President and Secretary.
Then we will go with
they will
Alva
join.
Society President, Dr. Abba. If you are there, we want your blessings for the success of this webinar. Dr. Abba. Okay. Dr. Bahalpur Society, Dr. Biba Chaudhary, anyone from Alvar, Dr. Charu?
From Alvar, Dr. Richa is there, ma'am. Immediate past
Then Dr.
president.
Richa can talk few words. Dr. Richa from Alvar.
Very good evening to all. And this is a very good series for our knowledge upcoming. And I give wishes to Dr. Sampat Kumari ma'am for their next session and for their upcoming elections. We are with you all, our society with you, Dr. Sampat Kumari. Thank you, ma'am.
Thank you, Dr. Richa. Before that, I also will tell that I am contesting for Foxy President. The election year is 2026. Time is August 1 to 10. I request all of you to vote for me from South. After 30 years, we are from Tamil Nadu. We are contesting. Next, we will go to the Bahalpur Society. Dr. Biba, Dr. Varsha, any one of you is there? Okay. Dr. Bidar Society, Dr. Uma, Dr. Savita.
I think Dr.
Hello. Hello, I'm Dr. Uma Deshmukh.
Yes,
And
yes, madam.
Savita, both of us are here.
Savita ma'am is also there.
Yes, both
thank
of
you. Thank you, madam. I'm unable to in, madam.
Yes, ma'am. We can see
You
both.
Okay, Dr. Uma.
I have joined in a one phone only.
Yes.
Unable to join in my phone.
Oh, okay.
Okay. Dr. Uma is the advisory committee member of PCP and DT Act, nodal officer for maternal mortality. And she is the trainer of SBS, EAC, PPIUTD, all government program. I think Dr. Uma madam is there. And I am a vice president here and the president of a Bidar Society, EC member for Women's Wing, and received many awards. Best Doctor Award, Sarvatam Seva Prashasti Award from Government of Karnataka, and Aspiring Women Award, Appreciation Certificate from Rotary Club, Karnataka State, and from
It's
IMA,
okay, madam.
FBA. Thank you so much, Uma madam. Dr. Savita. Dr. Savita is the secretary of Bidar OBGN Society. Few words from
Yes,
Dr. Uma and Dr. Savita.
Hello, madam. We are very much happy to join you, madam. And it's a good new series you have started, and it's a very necessary. This topic is for induction of labor. Thank you very much, madam.
Thank you. Thank you, Dr. Savita. Dr. Uma?
Ma'am, that was Dr. Uma, ma'am. Myself, Dr. Savita.
Oh, sorry.
Very happy
Yes.
be a part of your this series, ma'am. And we really congratulate you and also wish you all the best for your contesting. Thank you so much, ma'am.
Thank you, Dr. Savita and Dr. Uma. I need your support from all your places.
Yes, madam. Definitely, madam.
Dr. Madurai, Dr. Gayatri, and Dr. Sudha is there, I think.
Yes.
Good evening, madam. Madam,
Yes,
let us first give you advance wishes to have a wonderful slide in the upcoming AICOG President election, madam. We are all with you, madam. You are a real inspiration to us, and this series is really good. And you are just amalgamating the entire India in one series, madam. All the best for your further interventions, madam.
Thank you, Dr. Gayatri. Dr. Gayatri is a wonderful person, and she was doing a wonderful HPV vaccine campaign. Last week and all, she has made around, I think, 2,000 HPV vaccination for girls and also for boys. Till now, I have also never made that vaccine for boys. From her, I have learned. I will go for my boys in my college. First time. Next week, I am going to. Thank you, Dr. Gayatri. Dr. Sudha, are you there? Or we will go with the scientific session. Madhumita, you have.
Alva, Dr. Abba Sapra has joined, ma'am.
Dr. Abba, madam.
Abba
Dr.
Sapra.
Abba Sapra. Dr. Abba Sapra, are you there?
Ma'am's name. Yes, ma'am. Ma'am's name is there.
Hello, very good evening, everyone.
Welcome, Abba. Yes, madam.
Yeah, Dr. Abha from Alvar, President, Gynae Society. Yeah, very encouraging this webinars and very important topic you have selected. And many a times we are at hitch selecting the patient
Yes.
and choosing what protocol to need in preterm labor. So this is very nice, ma'am, and very encouraging also. We'll look forward also for many more webinars, and I would like to join every time. Thank you, ma'am.
Sure, madam. We will send the link. Yes, welcome, Dr. Abha, madam. Madam, I need your support from throughout Alvar
Yeah,
for my
sure,
election.
ma'am, sure.
Sure, madam.
Sure.
Okay.
Yeah.
Mm. Yes, thank you, madam. Shall we go with the scientific session? Madhumita, will you
Yes, ma'am.
introduce the moderator and the panel?
Yeah, yes. So moving on to the very interesting panel discussion on induction of labor. It's my privilege to introduce our moderator, Dr. Nandita Thakur. Ma'am is a medical director at Nandita's Fertility Center at Chennai, and she's also the academic head and coordinator and senior consultant at Mehta Hospitals. And she's very well known as a great teacher. And we have our expert, Dr. Richa Gupta, ma'am, who's the immediate past president of Alva Society, and she's also the senior consultant at City Hospital Alva. And ma'am is also the joint secretary of Nachi Rajasthan, and she's also the member of the Practical Obstetric and Gynecological Society. And she has numerous. And she's done numerous public awareness programs, and she's received numerous awards like the Nari Shakti Award and the Best Gynec Doctor Award from IMA Alvar. Next, we have our eminent panelist, Dr. Jyotsna Hanam Shetty, who is the consultant obstetrician gynecologist at Bidar, and she specializes in minimally invasive surgery and infertility. We have Professor Dr. Nandini, who's a professor at Government Rajaji Hospital at Madurai Medical College, and her focus of interest is high-risk obstetrics and gynec endoscopy. Dr. Mangala Lakshmi Preetham, who is the clinical director at Preetham Hospital and Endoscopy and Fertility Center, and she's an executive council member of the Madurai Menopause Society. And the eminent Dr. Priya Kannappan, who is the South Zone coordinator of the quiz committee of Foxy, and she's also a senior consultant at Mehta's Hospital and GFC Fertility Center at Chennai. Dr. Vijay Lakshmi, who's a senior assistant professor at Department of OG at Government Rajaji Hospital, Madurai. Dr. Gomati, who's an obstetrician and gynecologist at Mada Medical College at Kundratur, and she's also a life member of Oxy. Dr. Sadhana Devi, who's a consultant and fertility specialist at Yogesh Fertility Women's and Urology Hospital at Chennai, and she focuses on high-risk obstetrics, fertility, and laparoscopy. And we have Dr. Preeti Jawanlal from Akolo Obstetric and Gynecological Society. Dr. Divya Chandrasekhar, who's an assistant professor in OG, and she's in government service currently. Moving on to the panel. Sathi, will you be sharing the screen?
Yes, ma'am.
Yeah.
Can you see the screen, ma'am?
Yeah. Thank you. We can see, all of you can see the screen?
Yeah.
Yes, ma'am. Slide, please. So, as we all know, induction of labor is a very, very important topic. We come across cases on day-to-day basis, and to choose a protocol for induction so that we can artificially stimulate for uterine contractions and to facilitate, vaginal birth is the whole purpose of this process of induction. So to the next question, what are the common indications for induction? Suppose you have a case of late preterm condition or an early preterm or a late term or a post term. So which condition would you choose for at least a late term or an early term? Can we discuss those? The other two are quite defined. So can I get the panelists to answer?
early, so late preterm, ma'am, like exactly from 34 weeks, 0 days to 36 weeks, 6 days.
Okay.
We can take like, severe preeclampsia patients, like
Okay.
abruptio placenta, and eclampsia. So these patients we can go for late preterm induction.
Yeah. So for the next part?
And
Early preterm, it's between 37 weeks and 39 plus 6 weeks. So it's the commonest scenario we see in our government hospitals. So many cases of GHD and gestational hypertension, diabetes, oligohydramnios, and UGR patients, UGR cases. So these are the commonest indications we see in the early term.
Cite the previous slide, please. Yeah. So we all are quite aware of this ARRIVE trial. And do we do elective induction at 39 weeks? What is the rationale of this study? Can somebody throw light?
ARRIVE trial actually compares the outcomes in expectant management and patients who are electively induced at 39 weeks. So they have in this trial they are saying that this reduces the cesarean section rate. Meanwhile, it doesn't increase the other neonatal and maternal morbidities like chorioamnionitis, PPH, and all those things.
And there was also slight reduction in hypertensive disorders.
Yeah.
Okay. Dr. Richa, who's our expert, ma'am, would you throw some light, ma'am, on this?
Yeah, she's already told that key findings for elective induction at 39 weeks in low risk nullipara. And there was a reduced cesarean section rate, no increase in adverse neonatal outcomes, and there was slight reduction in hypertensive disorders. However, in Indian scenario, widespread adoption required caution due to resource limitations and monitoring infrastructure and high patient load. So, careful patient selection and institutional capacity are essential before adopting routine elective induction.
Thank you, ma'am. Next slide, please. So, depending on the Bishop score, what would you choose as your method for induction?
The Bishop score is like not favorable, less than 6. We'll go for initially with mechanical dilators like Foley's. If it is or maybe we can also choose prostaglandin E2 or misoprostol if there is no indication to prevent hyperstimulation.
Okay.
So depending upon Bishop score, we'll select the induction of labor method.
Okay. Pharmacological, do you use combined methods, like if Foley is followed by gel or Foley is followed by tablet?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am. Combined method will increase the chances of normal vaginal delivery. So we use combined methods. If there is a good like a CTG, everything is reactive, and we expect normal delivery, yeah, definitely, ma'am.
Okay. So we have, does the panel agree to this?
Yeah, combined methods, ma'am, like mechanical agents like Foley's catheter and also the misoprostol tablet, it will reduce the induction delivery interval, ma'am.
So
And
how do you,
also,
if the patient expelled the Foley, say at 3 centimeters,
3 to 4
and
centimeters.
she's getting relatively good uterine contractions, how would you proceed?
Yes, ma'am. I'll repeat my miss. I usually follow the Foley's bulb induction along with the 50 to 60 ml of normal saline. When she expels, after that, depending upon the uterine contractions frequency, if the contractions are adequate, I'll wait for another 2 hours. Otherwise, no means again I'll repeat my misoprostol dose. That is 25 microgram every 4 to 6 hourly. I'll repeat depending upon the NST. If it is normal, then only I'll proceed with the induction.
Okay. Here, the combined method, are you meaning whether you use Foley along with that, whether are we using misoprostol or Serviprime gel? Because there are a few people who are using that but those are outside guidelines because none of the guidelines support combining two agents together. That is, you cannot put a Foley and then give the meso. We don't have evidence to support that. But one method followed by the other, and I think as already agreed by the panel, if your your contractions are inadequate, you cannot have a normal vaginal delivery, normal progression without effective uterine contraction. So if your uterine contractions are inadequate, definitely you will be adding another agent depending on your Bishop score. If your Bishop score is poor, I think you will need a misoprostol or a Ceviprem gel. If your Bishop score is good, then you will augment your labor with oxytocin.
Okay.
In combined methods, we can use Foley along with oxytocin induction also, ma'am.
Okay.
That is also suggested now as per NHM guidelines.
Okay.
Not together, doctor. I don't think so. Because NHM is more worried about hyperstimulation. They say misoprostol could not be used.
No, ma'am, oxytocin.
Not
Because
along with the
oxytocin
Foley,
can be stopped immediately if there is a
not
hyperstimulation
along with
or
the
any
Foley. No,
response.
doctor, I don't think so. Not
As-
along with the Foley in situ.
As per Samarth Ram sir, from as per his programmed labor protocols, ma'am, he says we can go with Foley's bulb induction along with misoprostol 25 microgram tablets vaginally. That as per the programmed labor
Ma'am,
protocols, we
actually, we
can.
have been doing those things. What is happening is recently we had a NHM meeting in Tamil Nadu. Okay. So
Yes,
there,
ma'am.
that is the National Health Mission director and all the secretaries and everybody, they have come. And they have told that misoprostol should not be used as a inducing agent itself. That is the thing which they have told. I don't know about other states.
Yes,
But
ma'am.
for
We have
us, they have
discontinued the
told us
use of
not to use.
misoprostol for long. We have never been using misoprostol for term induction.
Yeah, but many people
We
are
are
using
using,
it. We
we
are
are
using.
using,
I've
we are
used. I
using
have
and
been
with
using it. But
with
now
very
the
good
NHM is
results.
telling it should not be used.
Can we speak one by one, please? Because it's like overlapping. Yes, Priya, you finish your point, then
So now recently, like last week, we went and had a NHM meeting with all the people from all representative from all over Tamil Nadu. People who have been there will know that both private and government sector. We had with the NHM experts and the NHM director. They told us misoprostol should not be used for induction of labor in term. That is the reason recommendation by the National Health Mission. Till we get a clarity, we are not in a safe term to use it. So that is what is there. As for Tamil Nadu is concerned, because you have to come to a consensus. I think a team of experts should have a data to discuss with the NHM, and if they agree, I think to go ahead because they are the people who are going to audit maternal and neonatal morbidities. So if you have a loss of either of them, or if you have a near miss case, we are going to go with a discussion with them, and they are not going to support us if we use misoprostol. So that is what is the status for us.
okay, doctor, can you? Somebody else was talking on
Yes,
this.
ma'am. Ma'am, the NHM has given clear guidelines not to use misoprostol for term long back, and we have discontinued the use of it almost since 4 to 5 years. We have never been using, even in case of PRON cases where we are not able to use the Serviprime gel, we are not using the misoprostol.
Okay. Dr. Richa, would you add anything on your side?
Yes, in Rajasthan state, we are using, and there is also NHM guidelines does not does not NHM guideline recommends the use of misoprostol for induction of labor, and SOGC guidelines 2002-3 also recommend misoprostol for cervical tightening when the fetus has a normal CTG, and but suggests the caution in potentially compromised fetus. So, and in our government and private setups, we are using misoprostol with a very good result. But the proper monitoring is required, and we should repeat the dose cautiously, not very frequently. The dose should be repeated every 4 to 6 hourly according to the uterine contractions and the effect of misoprostol.
To add on, what the NHM expert told us is misoprostol is not approved by the Food and Drug Administration of India. As of now, as per law, misoprostol for term is not approved under drug safety. That is the reason which was given to them. So till we have a clarity, all over India, we are not very safe to use that for induction. We should know this point.
So I think, when we are having so many queries, all us people who are from the different associations can come together and put up a proper consensus. So
yeah,
that
and the Foxy should clear this.
Yes, and Foxy should clear. So our parent body should give us a go with that. Okay. So I think anybody else wants to add anything extra? Otherwise, we move on. The other panelists? Okay. So I don't think we have on that much. Now we'll do a few special situations. Supposing you have a GDM mother, reasonably controlled GDM, what would be the timing and what would be the method of choice for induction? Can we start? Can somebody take up this, please?
GDM on meal plan, and the sugars are well controlled, then we can induce at 40 weeks of gestation age, ma'am. If the patient's GDM on insulin, then we can terminate at 38 weeks of gestation age. And the choice of methods based on the Bishop scoring, we have to plan.
Okay. Somebody is GDM on insulin, so not very well controlled. But
better to go for elective LSCS, madam, if it is not well controlled.
Okay. Any other opinions
We
on
can
that?
do elective induction, ma'am. After getting proper consent, we can do induction in patient, explaining the complications like there will be failed induction, maybe increased rate of cesarean rate. You can also go in for cesarean. So we can explain all that with the consent from the husband and the wife. Then we can go for elective induction first. And then if it fails, then we'll be moving on to cesarean.
Okay. Any other factor that you like to look at before you start?
Obesity, ma'am. Obesity, definitely. Weight of the baby. And of course, Bishop score also we have to see.
Okay.
BMI of the mother also.
And as it is an uncontrolled GDM, madam, so definitely baby size will matter a lot. So whether there will be any risk of shoulder dystocia and pelvic adequacy, that we will see for.
Okay. So basically, we need to give a proper assessment of the maternal condition, her medical status, whether she is okay, there is no evidence of major CPD that we are missing out, and whether we can take the risk of inducing this patient by monitoring her sugars, keeping her on insulin, keeping your sliding scale, keeping your endocrine person or the medical person in, to be there in case of problems, issues, that we know there are neonatal issues, and in labor itself, we can have concerns. So these are things that we really need to take care in a GDM mother. Anybody would add a point, or shall we move to the next?
So if it is uncontrolled sugar, most of our guidelines says to induce early, somewhere between 37 to 38 weeks, that is 37 completed weeks. The only thing is GDM, even when they are term, they can have RDS because the surfactant release will not be good. So a 37 or 38 weeker is going to have RDS. So I think, as you have already rightly pointed out, madam, we have to just counsel the patient, provided whatever method, the baby will have RDS, the baby will need a NICU stay, and depending on that, and the most worrisome is intrapartum stillborn for a patient with uncontrolled diabetes. So that we have to put, and whenever you're inducing, you have to maintain the sugars continuously within the range of 100 to 120. Less than 100 is always preferable, so that well-controlled sugar will prevent the stillborn risk, and continuous monitoring of the baby is very important in an uncontrolled diabetes.
So we'll move to the next condition. If you have an FGR baby, the previous slide, the second part we're doing. FGR with normal Dopplers. Say the baby is on around the 5th to the 10th centile. Okay. Then how would you take this pregnancy forward? She said 34 weeks or 35 weeks now.
Ma'am, we have to check for the Doppler, ma'am. Even the baby's FGR, we have to check for the Doppler. If the Dopplers are normal, we can definitely wait. And we have to do twice a week Doppler, or I mean, a week, 10 days once we have to do Doppler. And also we can do NST. So if the doctors are normal, we can definitely monitor and observe her. And in case of severe FGR, also we can just wait till 37 weeks.
Okay. Any other opinions do we have?
Even with normal Dopplers, ma'am, FGR even with normal Dopplers, I think we have to early term only we have to induce the labor from 37 weeks 0 days to 38 weeks 6 days, ma'am. Early term we have to induce even with normal Doppler.
Okay. Anybody else with a different?
We have to assess whether she has any other complications. Mostly see FGR with the preeclampsia. So in that case, this gets categorized as severe preeclampsia. So all those things we have to consider before inducing.
Yeah.
But in plain case of FGR, it can wait till 37 weeks, provided the Dopplers are normal.
Yeah.
Okay. So if it's pure fetal cause, we can monitor the fetus and take her forward. Any intervening maternal condition, which is like onset of the hypertension, which is more common one that we see, or if she's a GDM with FGR, that also you can have a situation.
Yes.
So we really have to assess maternal conditions and then see what is the method we can do. What method of induction would you opt for?
We usually assess the Bishop's score, madam, and then we will see how it is. So most probably they might need Foley induction followed by the next method, continuous monitoring of the fetal heart rate.
Okay. Any, Richa ma'am, anything that would you contribute on this?
I want to ask all the panelists, how many of you are using Foley's catheter in day-to-day practice?
I use.
We are using.
We are using, ma'am.
We are using.
ma'am.
In term pregnancy or in IUD?
Both.
In term pregnancy,
madam. Term pregnancy.
In term pregnancy, all my inductions are Foley's, madam.
After this, are you using gel with Foley's or only Foley's?
Only Foley's followed by
followed after expansion.
Okay.
I think most of South are using Foley's catheter, ma'am. Some are using Propus. Cerviprime gel is, of course, prostaglandin E2 gel is also being used, but the use has definitely come down after the introduction of the Foley's catheter. How is it?
But in North, the use of Foley's catheter is not so frequent. We are using misoprostol tablet or prostaglandin gel.
So we have two different views, and both the ways. I think the aim is to just get to vaginal.
Safe vaginal delivery. Safe vaginal delivery. Yeah.
Yes. Okay. Next slide, Ma. Okay. So if you have a term PROM, how would you proceed?
In a case of term PROM, we have to assess the Likert, CTG, as well as the Bishop's score of the patient. There are two methods. Either we can give an expected management or immediate induction. If you go for expected management, there should be little or few drops of Likert draining so that we are monitoring the patient. If it is then delayed induction gives you a little bit a good rate of normal delivery. But if there is heavy draining, it's better to go for immediate induction.
Okay. Anybody else? Any other factor that you want to consider?
It's better to avoid Foley catheter in PROM. So we never resort to Foley. But even though gel success rate is less with it, we go with gel.
Okay. Anybody else?
We have been using misoprostol, madam, but now that the NHM has told us not to, they say you go with injection syntosanol. I think we are still, to apply. I mean, to apply that and then to see. So I don't know that about that. And there are few people who wait for up to 12 to 24 hours. But seriously, I get scared of waiting in a term PROM. I am always for immediate induction, but there is a view that you can wait. Most of these patients will go into labor.
Okay. Anybody else? Jyotsna or somebody? Dr.
Yes, ma'am.
Nandini?
Like as madam said, like we can wait if a liker is normal, CTG is normal, we can wait for 12 hours to have her a spontaneous onset of labor. If not, then we can go for a induction with
Oh,
gel.
fine.
So that depends on the bishop score too. Suppose the bishop score is favorable, you can they
Yes, ma'am. Yeah.
respond to oxytocin.
Yeah, definitely, definitely.
Correct. So,
But in this situation, we also take the condition of take the mental status of takes consideration the mental status of mother also, because sometimes in case of PROM, because of draining of liquor, the mother is very much uh, anxious about the fate of the baby. So sometimes we have to make a decision according to their mother's condition also.
I think it is more like a holistic approach than just looking at,
Yeah.
okay, the primary concept of we want to do a vaginal birth, but we need to consider all other factors, and that will probably evolve around our decision making. Okay.
One
And
more thing,
always to
ma'am,
rule out
also in
sepsis.
PRM. Yeah.
Yes.
Yeah, sepsis. Yes, ma'am. I wanted to tell that one.
That's why I kept asking what else. Okay.
We
Because
want to see the
sometimes
count of. Yeah.
we just presume that term
Exactly,
PROM will not go into sepsis. But even in a higher end class of people also, we have had foul smelling liquor also I've seen. So it is not like, you have to just have that in top of your mind also. So if you feel sepsis, then immediately induction under antibiotic cover.
Also, the
Yeah.
counts we will see, ma'am, like WBC
Okay.
counts.
Okay, we'll move to the next one. Now, lady who's got a higher BMI, like 35, 40. Today, we are seeing that trend of a higher BMI. Okay, so what are the challenges that you face during managing such a patient, especially related to induction? What are the challenges?
In higher BMI patients, we often see very unfavorable cervix movement. These patients have a prolonged latent phase, and their success of induction is also very less. And even the oxytocin response is very poor in these patients. So these patients, they have complications, GDM, PIH, everything put together. All these things complicate, and higher cesarean section rates are there in these patients.
Postpartum hemorrhage also.
That's postpartum hemorrhage.
So would you go through a full induction? Supposing you're doing Foley's, you go through the 24-hour followed by something, or would you say, okay, I would like to cut short using gel? Is there any difference? It becomes very difficult for us because there are no definitive guidelines to say, okay, if it's obese, it is this. It's more like, we work with how the hospital setup works or what we have been familiar with. I think this is a thing. Is there any guideline? I don't think there's any. Ma'am, Richa ma'am, anything that you would add?
No, there is no guideline. We have to take a decision according to
Case-based
individuals.
decisions.
Yeah.
Okay.
Yeah.
A little more trickier situations we move to. Supposing it's a previous LSCS case. And this patient said, okay, I've got a long gap. I want to try vaginal birth. What's your take on that? Do we induce these patients? If so, when? How?
In a case of previous C-section, we see whether what is the indication of previous cesarean, madam. So if she has already on labor and the pregnancy was terminated because of any fetal distress and she was with good bishops or 6 to 8 centimeter dilated, the chances of successful TOLAC is very good. So we always explain the pros and cons to the patient. But since she is a case of breach or severe oligo or any Doppler changes, she has undergone emergency LSCS without trying for a normal vaginal delivery. Even the interval is so good. We say the chances of giving a normal vaginal delivery, and then we assess the patient, madam.
Okay. Anybody else would add?
When the patient insists on normal vaginal delivery, we see that she has no comorbids, GDM, PH, we rule out everything, and what was the previous indication. All those things we assess beforehand, and it's better to wait for spontaneous onset at least till her EDD when her dates are good. Because with the spontaneous onset, the chances of VBAC, TOLAC success of TOLAC is good. So, and then we go for induction with Foley for these patients.
Right. Amazing.
The more near the term we wait, the chance of toe lac is better, madam. But again, it also increases the chances of rupture uterus. We see many of the patients, they come back in labor with such a thinned out lower segment, maybe a scar dehiscence or almost like a rupture itself. So this is like, a knife with a double-edged sword. That is what we are going to face. So, if you have a setup where you can do emergency LSCS anytime, then waiting for a toe lac, inducing a patient for toe lac, and a setup to manage all the other complications for rupture uterus you have, then you can go for that. If you are in a smaller setup and these are not there, I think safety of the mother and child, elective section is better for them.
So it demands a good infrastructure and good resources to monitor the patient. So that's
Yes.
the drawback. They are the limitations.
There are no contraindication for this particular patient. At what time we can plan for elective section? No other medical comorbidities, no other contraindication.
Actually, according to the NHM, they say you should plan delivery by 39 weeks. Okay, but we put this word forward. We said if you want to wait till EDD, then it is 40 weeks for them to go into toe lac and then to take for section. Then the 39 to 40 is a gray zone as per every information as available to us. Okay, so if it is an elective, it's 39. If you have decided it is a recurrent indication or this patient is not a candidate for toe lac, then if you are planning for elective, then we can deliver by 39 weeks. There is no doubt at all. But if you are planning for, to give a toe lac trial, then you have to wait till the EDD 40 week because most of them go into spontaneous labor and having a spontaneous labor increases the success rate of toe lac.
Okay. So is there anything in that first pregnancy or during the cesarean of the first pregnancy that you'd want to look at to decide for toe lac?
Classical or team?
Classical
I would love to have the operation notes, but never the patient brings that, madam. Not even once I've seen that in the second pregnancy because those notes are always missed by the patient.
Very important whether it was a second stage labor and whether it was obstructed labor. They never mentioned whether it the extension of incision ever, but that is very, very important to decide.
Also, any other major surgeries other than cesarean in between the pregnancy?
Myomectomy. Many times they don't tell us also because that can be like, before marriage, then they don't tell you at all.
Sometimes patient hides cesarean section also because of
Second
because of
marriage.
they want a normal delivery. They said there is some another operation, some of operation of ovarian cyst. Sometimes this also happens.
So I think
we have to take.
Yes. That is the one of the reasons why I brought up this thing of previous LSCS. I think it's just not toe lac that we focus on. Go back, look at the history, find out the reasons, and I think basically, we have to be very vigilant because ultimately the gun points towards the OGCN. And I think as OGCNs, we should consciously make an effort to put our notes down. Even if there was an extension or we had to do a incision which is slightly different. Hematoma formations, because that is forming a weak scar. I think, at least for our document, we need. If the patient comes back to us, it will be good. As a team, if we work, so wherever the patient goes, the documentation becomes very good. Okay. Now we are looking at a surge of ART pregnancies. The next discussion will be ART. Singleton, otherwise low risk, no complications. Would you consider vaginal birth at all? If so, would you induce or will you ask her to get into any spontaneous labor?
Singleton nodes, definitely we can wait, madam. Can wait till 39 weeks and we can have 39, 40 weeks we can wait and we can have elective induction if there are no other complication, lower risk pregnancy.
Okay. Anybody
Even
else?
if it's IVF.
Yeah.
Engage male factor with a good liker, good Doppler, Bishop's favorable. So definitely we can give a try, madam, after giving an informed consent, because since they are going for an ART, they always don't need any, they will be not willing for any fetal distress or any, we say after birth, if the baby is in distress. So we have to explain all the pros and cons to them, ma'am.
Okay.
One big problem with ART pregnancies is that, madam, they are not mobile for all the 10 months. Tell them exercise, put them on a program. Hardly 10 to 20% of the takers go and do exercise. They are all bed bound for all the 9 to 10 months. and then suddenly coming an induction, most of the time they land with failed induction only. So I think that we have to counsel them if they are ready for, like, they want to try for a normal vaginal delivery. I think they should be a little more active throughout pregnancy. So that is so that we don't land into a second section where the head doesn't descend but the cervix opens up.
See, the problem I think we all face as obstetricians is that we, there are people who instill so much fear in the patient. Patient gets scared, and it's like becoming a patient's demand for cesarean at the end of the day, though everything might be favorable. So, we are walking on a very thin rope. Probably we'll discuss a few points under maternal request also. Any other thing on ART pregnancy, or we'll move on from here? We'll do a post-dated pregnancy. When would you want to induce? 40, 41?
41.
42, according to the
If she's a low risk pregnancy with no other maternal complications, we can go from 41 weeks to 42 weeks, ma'am.
Okay, so when would you induce, doctor? This patient is 41 weeks today, or she say 40 weeks, 6 days. Say tomorrow she's 41 weeks. Would you want to
from
deliver
41 weeks?
Yeah.
Practically, we don't wait until 41 weeks.
Okay, no, okay, you don't wait. Fine. So you would take her up at 40 weeks.
Yes,
so
40 plus 40.
Days
I would definitely wait after 41.
Okay. Then anybody else?
Each institution has its own SOP, ma'am. So in Madurai, we follow 40 plus 2. So beyond that, we see there are so many, the lichen suddenly comes down, there are increased incidence of meconium staining, all those things we see. And hence, we admit her at 40 weeks. We ensure the dates, we see her, it's correct dated, and then we do a membrane sweeping. We keep her in inpatient. And at 40 plus 2, depending upon the Bishop score, we choose the method for induction and induce her.
Okay. There are a lot of cases that we see, they're very adamant they should have a vaginal birth, and they refuse even admission. They don't want to come for, they don't even allow an internal examination, pelvic examination, because they hear certain, Instagram posts and certain, followers are there, some preachers are there that we are facing these challenges. They don't want. So how do you document a refusal consent in such patients? How would you counsel them? How would you document? See, this is something which we are facing a challenge. It may not be every day, but it is there, and it's becoming more because there's a lot of noise on cesarean section to bring it down. So this is something common pointers that we can all use in practice. Can we start with somebody?
Actually, this is happening nowadays a lot because because of the Instagram, and so many people say they have given each and every individual is unique, that we have to tell to them, and we have to ask them to ensure the safe vaginal delivery and the well baby and good. It should be the end. The baby should be good as well as the mother should be good. So one time at 40 weeks, the internal examination should be done. If they refuse, it should be documented properly, madam. Then a Leica, Doppler, and CTG monitoring. Most of the time, at 40 weeks, we always ask them to get admitted. Even if they are not willing to get admitted, then that also should be documented that patient is not willing to get admitted. And then we ask them to review every day CTG.
The Madurai Society, I think, more or less similar guidelines. From the north, anybody different? Richa ma'am?
In here, generally we induce at 40 weeks. If the patient is not counseling for this, we have to write down in our OPD that there is a risk, and we should write down each and everything in our OPD slip.
So I think that will be the take-home point for this pointer. Maternal.
We don't have electronic medical record for OPD, madam. So I think if you have an electronic medical record for OPD, that if you don't have it, at least have it documented in your emergency record or somewhere in that, so that at least as an IPK sheet, this informed refusal is there in the hospital record, so that whenever there is an issue later on, you will have a backup plan to keep yourself safe.
Okay, next slide.
Yes.
Next slide, ma. Sahiti, next slide. Okay, we'll move on to maternal request. We are now seeing changing scenarios in our practice, requesting for cesarean, requesting for induction on this day. Where do we stand with that in practice? I want your viewpoint, and medico-legally how we can back ourselves. See that today we are facing many challenges. Jyotsna ma'am?
Ma'am, like when they come with the request of asking for cesarean section, our duty is to explain her if she is a low risk pregnancy, what is her condition, is there an indication like space for the induction of labor. So everything we have to explain her. Even after a proper explaining and after proper guidance to her, she is not willing. Then I think we have to go for a cesarean section, and we can write at the indication LSCS at request or cesarean at request, because we cannot like after all, because cesarean we are doing on the mother only. If she herself she is not ready, means our duty is to explain her and like make her understand what is the situation.
Correct. Anybody else with a different opinion?
These are day-to-day challenges which we are facing, madam. But I don't know this will be like time change now, because again NHM has give us a new form. I think some 4 or 6 pages which you have to fill for every cesarean section which is happening from now on. And every month, every hospital is going to submit that full form, like how we fill the PNDT form to the NHM. They are going to analyze based on Robson's criteria, and their dictum is to reduce the primary cesarean section rate. So from now on, it's not going to be easy to do this. Though you can say the patient is coming and telling it to me, they will see at the flaws from our side that we have failed to counsel, and we have failed to clarify these records on that. So again, these are gray zones which I think the people from the heads of every unit should discuss with the government and bring to a consensus. If a patient is definitely not wanting for normal delivery, what a doctor should know, and that I think should come from the administration side.
Okay. So we are almost getting to the end of the thing. Quick last few questions. Failed induction, when do you call it failed induction? What are the controversies in the definition? Gomati ma'am, anything?
Failed induction is actually when we have tried for three times. So after 3 times only we used to call failed induction. But sometimes when the bishops is so poor, even with one single time, along with the fetal distress or the Doppler, they are going for LSCS. So that is the controversies. But when we have to call a failed induction, we would have at least tried for three methods or 3 times of the same method.
Anything else?
The recent guidelines, they say after Serviprime or prostaglandin, we have to add syntocinon as well as an inducing agent. And only with syntocinon also failing, we should define it as a failed induction. That is the actual definition as per the ACOG 2022, madam. So, I mean, that is what has been recommended. So, but we are doing a lot of things of the bishop score not improvising on latent. There is again a gray zone where what we do is initially they induce. There are few people who do that. Then they give it a break for a day or two, call the patient back, and again they induce. So these are out of guideline practices which few people are doing. We don't know. We don't have any backup to do these things. And whether the patient has not gone into active phase, then you take them even in the latent phase. Are we justified? These are again gray zones. We don't have any clarity on these things.
Okay. Fine. The importance of consent, I think we have discussed right through our discussion. So I think proper consent, explain the process to the patient, maternal fetal morbidities should be, documented that you have explained. I think this is something which is, evolving. There are consents available that we can use it. There's something very interesting coming up. Whether we do induction of labor as an outpatient procedure? Can we think of it?
Slide, please.
Have we? Do we have those on our even horizon in India? No, I don't think any of us would even dare do something.
I don't have the guts to do that, madam. Sorry.
No, but there are papers which have come out from Spain and, in Sweden. Like one of my niece, they induced, sent her home, and then, brought her back for delivery after about 8-10 hours. So I think, it's something which is coming up. There are papers we might see how much in Indian scenario. I think we should, work around it. So
I want to share something. In our state, is outpatient induction is done by the some RMPs, by the misoprostol tablets. Yeah, they are doing this.
Okay, so we have somebody who's already doing it. Maybe we don't have the guts to do it yet. Hope to get there, ma'am, soon. Okay, so one takeaway point each of you can get, and then we'll wind up the session. We'll start, ma'am. Who is starting? Jyotsna?
Yes, ma'am. Takeaway point, exactly, we should, time our patient regarding the timing of the delivery, timing of the induction is very important, and dating of pregnancy. Timing is exactly that I think we should consider.
Dating is what you say. Next, anybody else?
It should be proper consent should be taken.
Okay.
Explain detailed written consent should be taken before induction of labor.
Fine, very good. Next, Nandini ma'am.
Method of choice will be depending upon both the bishop score and also our preferences too, and what is available, and our experience with it.
Okay.
We will have to think for some guidelines for higher BMI patients, madam, because now future is going to be a thing for PCO mothers and obese mothers only. So I think some research has to be there just to calculate or escalate the doses for higher BMI patients.
Point well noted, ma'am. Anybody else who's there?
Induction of labor, when the patient is induced, the patient should be monitored well, madam. Hydration status, ambulation, CTG monitoring, the patient wellness status should be monitored. Most of the time they don't drink or they don't know when to, hydration part is very nil oral status, and glucose monitoring. Sometimes they go for low sugars, giddiness. So these are the things that should be monitored, ma'am.
Priya, anything?
Time for cervical ripening is not included in calculating the length of induction, ma'am.
Okay.
And that is why we couldn't give a clear cut of definition for failed induction.
Okay.
If you are planning to do an induction for an elective case where you can even give 1 more week, so if your bishop score is poor, you're waiting for that 1 week will definitely help us to go and have a smooth vaginal delivery. So very poor bishop score, if there is no maternal reason or fetal reason for immediate induction, give the time of a week's time so that the patient has a successful vaginal delivery.
Okay, so we'll have our expert Richa ma'am to give the final word.
Yes, so all of them told that I will summarize this, that induction of labor should not be viewed as a routine intervention, but it should be a carefully planned obstetric strategy. And successful outcome depend on correct indication, appropriate timing, assessment of cervical readiness, selection of the right method, and continuous maternal and fetal monitoring. So induction of labor can significantly improve maternal and neonatal outcomes while maintaining acceptable cesarean rates. So this should be the take-home message, that we should correctly assess the maternal.
So thank you, ma'am. I think we'll come to the end. Thank you very much to all the panelists.
Thank you, madam. Thank you. Wonderful.
Thank you, ma'am. Thank you, madam.
Madam, are you there,
Thank you,
madam?
ma'am. Thank you, ma'am. It was wonderful, ma'am.
Somebody, madam, you're there, madam.
Yes, ma'am is here. Ma'am is here.
We have a lecture. We have a lecture. We have a lecture for.
Yes, madam. So thank you so much, esteemed panelists. That was a wonderful discussion, and and a very special thanks and gratitude to Nandita ma'am and Richa ma'am, our moderator and expert, who conducted the panel so well. Sampath ma'am. Ma'am, you're muted, ma'am. Sampath ma'am, you're muted, ma'am. Ma'am, before we move on to the talk, Dr. Mevish Khan, ma'am. I think ma'am has joined. Akola secretary, I think ma'am has joined. Mahavish ma'am? She was here, I think. It's disconnected, I think. Okay. So, shall we move on to the talk?
Yes, Madhumita, we can move.
Yes. Mahavish ma'am? Okay, I think she's disconnected now. So
Gayatri madam is there, no?
Yes, ma'am. Gayatri ma'am is there. Yes, ma'am. So moving on to the very interesting talk on PPH, we have our esteemed chairperson, Professor Dr. Gayatri ma'am, who is the professor of Government Rajaji Hospital at Madurai Medical College. She's also the president of Madurai Obstetric and Gynecological Society, past treasurer of MOGS, and also the former HOD of Pinnacle Medical College. She was also the secretary of Women's Wing of IMA and former joint secretary and joint treasurer of MOGS. And she has a very long years of UG and PG teaching, and she's also a UG and PG examiner, and she's an eminent faculty at various conferences. So over to you to introduce Sampath ma'am.
Sampath ma'am needs no introduction to this august audience. To add a few laurels to her, she was the vice president Foxy, which is a very honorable and a very difficult post to get unless you are academically highly oriented. She is a Senate member, Tamil Nadu Dr. MGR Medical University, National Corresponding Editor, Journal OG of India, Jogi, and mainly the founder secretary, the most renowned TNFOG, President Oxy, Motso, retired Deputy Director, IOG MMC Chennai, President Board of Studies, Tamil Nadu Dr. MGR Medical University, chairperson for Foxy Adolescent Health Committee as early as 2016-18, first ICOG Distinguished GC Member Award on 2021. She is also the chairperson Women's Wing of IMA Chennai South, and she has won the IMA National President Award and IMA TNSB Award 2021. And more so, she is one person who is competing for our Foxy president, and all of us should support her full-heartedly for her to win this elections. All the best to you, and over to you, ma'am.
Thank you, Dr. Gayatri. Thank you so much. And I welcome all the presidents and secretaries of the society. And we will go with the talk of PPH. I think Dr. Madhumita will share the screen. Dr. Madhumita?
Yes, ma'am.
Yes, as Gayatri madam told, I am contesting for Foxy president. All of you, please vote for me. Now the talk is postpartum hemorrhage. Almost all of you would have seen the postpartum hemorrhage in your practice. This is the one incident. We do not know for whom the postpartum hemorrhage happens. Next slide. See, the PPH women are not dying because of a disease we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. This was done, told by the FIGO president in 1997. But still, it's going on this PPH. Next slide. See, what is PPH? PPH is the normal blood loss, which is around 400 to 500 ml within 24 hours of the delivery. But the incidence is 4 to 5%. But if it is high risk cases, we will be well prepared. If it is a cardiac disease or preeclampsia or whether it is diabetes cases. But the normal patient, when we comes, we think that it is a very casual. But this normal patient can also go for the PPH. This is the primary PPH. Next slide. The secondary PPH being the bleeding which occurs after 24 hours until 6 weeks. So the blood loss is the amount which the patient is losing. We cannot assess. That is, we cannot take measurement. But only our visual inspection, examination alone will help for the management of the PPH. Next slide. What are all the causes of the PPH? See that MMR. Now we are talking about MMR always. Now the MMR has reduced. But among this, 47% of the maternal death in rural India is mainly due to anemia. It can be the direct cause or the indirect causes. So the anemia, if you go for the PPH, again it will end up in the anemia. The next slide, please. The maternal death, as we are telling now, the maternal MMR is reduced in India, that too in South, the Kerala is the number one. In Maharashtra is second, and other than that, all the places now it is reducing. Even in the north, it is reducing. Next slide, please. See, what are all the risk factors? We do not know which patient will go for the PPH, but still we can be very careful. Suppose if this history is present, antepartum hemorrhage, that is the prolonged labor, chorea amnionitis, suppose the baby is more than 4 kg, anemia patient, maternal obesity, then multifetal gestation, pre-eclampsia, prolonged labor. Most of the time, the patient will be referred from one place to another with a prolonged second stage. That cases and the previous PPH patients. So these are all the risk factors. You should be very, very careful. What we are always, we keep the labor kit everywhere in the labor ward with each table. Similarly, the PPH kit also should be kept in the labor ward, in the antenatal ward, and in the theatre. However, the 2/3 of the PPH occur in women with no history. Next slide. See, what are all the causes? PPH we are talking. See, what are all the causes? Always we talk about the 4 T's. That is the atonicity in 70% and the trauma in 20% and the tissue, that is the retained tissue in 10% and thrombin is only 1%. Because when a patient comes for the antenatal itself, we elicit the history of the coagulopathies, bleeding time, clotting time, any bleeding disorder. If anything is present, it will be ruled out. So that we are not going to elicit during the delivery time. So most of the common cause which is missed will be the tone, trauma and the tissues. What is atonicity? Next slide. Normally in the delivery, what happens? The upper segment contracts and the lower segment relax. So once the patient is delivered, the uterus should be like a cricket ball. If the consistency is like a tennis ball, then we know that this patient is going for the PPH. So always atonicity should be very rigid. Palpation itself, we can see if the patient is going for the atonicity. So once the third stage of labor is over, means we should see whether the uterus will come to the umbilicus and it will be seen in a thin patient, it will be seen prominently. So the atonicity is only the contractions that has to be measured. The next slide. So the uterus, this is the way we see the normal tissue. What is the tissue? The first stage is up to 10 centimeters. The second stage is delivery of the baby. And the third stage is delivery of the placenta. Once the placenta is delivered, we have to verify whether the placenta has been delivered fully. Always how we will deliver the placenta, I will show in the next stage slides. So this is the way we should deliver. Always once the baby is second stage is over, we have to keep the left hand over the suprapubic region and the right hand we have to hold the card. And with this, as shown in the first picture, we are going to deliver the placenta. Since we are given third stage of labor, we are following the style. Syntocin is given means the placenta will get separated by itself. Once it is separating, you receive the placenta with both the hand and then rotate. The placenta, the maternal surface is attached to will be like the cartilage, and the fetal surface will be like the membrane. So once it is delivered, first with the clamp itself to see whether the whole membrane is present. It will be like a cloud. So if the whole membrane, then lift the placenta and see all the cartilages are present. If there is any cartilage is missing, we have to verify it whether it is inside or not. If it is a small cartilage means we can remove. But if the full placenta is not delivered means you cannot do or remove it in the theatre, in the labor ward. It has to be sent to the theatre and under anesthesia only it has to be removed. So this tissue will produce the bleeding. Next slide. Next slide, please. Then comes the trauma. So the third stage we were talking. And the second stage, the delivery of the baby. Always we have to give the perineal support. Even if no one is there, you can ask even the attenders to have the gloves and give the perineal support. So we have to give the perineal support and the urethral support such that the baby will come. The mechanism, all of us will be knowing that. Yeah, extension, the engagement with the descent and the internal rotations and finally the external rotations. When the baby is coming out, if we don't give the perineal support, there's all types of the trauma will occur. Where are all the possibilities of the trauma? Next slide. The perineal support should be given till the delivery of the shoulder. Once the baby is head is delivered, don't remove it. Till the delivery of the shoulder, it is better to give the perineal support. If you don't give, that can be the sites in the vulva, so in the vagina, cervix. Suppose if you are going to give the fundal pressure. Nowadays, we are not giving the fundal pressure. That can be the posterior cervix tear, and trauma can extend up to the posterior wall of the uterus. So these are perineum and the paraurethral. If you don't give the support only, it will go to the VVF, RVF in future. So the perineal support in the second stage is very, very important. Next slide. So now we have discussed about the tone, the tissue, and the trauma. This is the way we are going to give this Amstel. So once the placenta, before the baby, delivery of the baby, we are going to follow the Amstel for all the patients. That is, administer the uterotonic. That is 10 units of syntocin to be given immediately after delivery of the baby. If it is the twins, means once both the baby is delivered only, we are going to give this oxytocin. The next slide. This is the Amstel, which is followed by the all followed in all patient. So the oxytocin always it has to be maintained in the fridge room. It is not maintained in the room temperature. It should be kept in the fridge. Most of the time it is kept outside. That is the reason. It can be also the reason for the PPH. Once the baby patient comes to the labor ward only, the oxytocin should be brought from the fridge. The next slide. Next slide, ma'am. This is the controlled contraction. This already I have told. That is how you are going to deliver the placenta. Left hand always keep over the suprapubic region. Don't keep over the fundus. And with the right hand, you receive the placenta and deliver it. Next slide. So since we are giving the suprapubic region, we are preventing the inversion of the uterus. So once the baby is delivered and the placenta is delivered, see, as I told, it should be like the cricket ball. If it is like the tennis ball, means massage. You can ask even the patient to massage the uterus or the attenders to massage. That is at the level of the umbilicus. Most of the time, for 50% of the uterus will become to the normal with the massage itself. Next slide. Next slide. Next slide, ma'am. So this is the way we are going to remove the placenta. As I told, if it is the single piece, you can go with the long gloves that is up to the elbow. You can go inside and remove the bit of the placenta. If it is the whole placenta, means go to the theater and go inside the uterus and like turning the paper pages in the book. Take you have the whole uterus in your hand and separate it from the fundus and the remote that is under anesthesia only. Next slide. Next. So this is one simple way always to measure under the gluteal region. This diaper, this is the blood collection drape. It is available in some places. It is available in our place in the government hospitals also. In this, you have the measurement that is up to the 500 cc. The red line will be seen. It is easier to make also. If it is available, we can assess the blood loss by keeping this drape to all the patients before the delivery of the patient. That is during the when you make the patient strain itself, you can keep it again under the gluteal. Next slide. So these are all the assessment. By simple, we can take with the kidney tray, if blood is there, means it will be around 500 ml. If it is a clot is present up to our hand, means it is 50 ml. So the blood is present throughout the table down and all, means it may be more than 2 liters. So whenever if you are going to assess, if it is more than 1.5 liters only, the symptoms will be present, the tachycardia, hypotension. Till the 1 liter of blood loss, the patient will tolerate. But don't wait till the loss of 1 liter. Once the loss is going more than 500 itself, means you have to start the treatment for the PPH. Next slide. What are the tricks which has to be given immediately? Always, if the patient is having the profuse bleeding, means 10 units or 20 units of syntocin can be started with a drip, and it has to be given. And if the patient is not a cardiac patient, and if it is not the eclampsia patient, you can go with the methyl ergometrin 0.2 milligram, but nowadays it is not given. And then the mesoprostol, magnesium phosphate and PGE2. This 4 tablets, that is 200, 4 tablets can be kept in the rectum. That will lead to the contractions of the uterus. And the prostaglandin injection, carboprastal, that can be given 0.25 milligram IM. Most of the time, the single itself will be enough. And if at all needed, you can repeat the dose also. So the drugs should be kept ready is mesoprostol, carboprastal injection, oxytocin, and methyl ergometrin if available in cases of the PPH. Next slide. Now we have this carbitocin. This carbitocin is always helpful, and there is no need for the maintenance. 1 minute, something. No need for a room refrigerator has to be maintained. It can be kept in the room temperature. Suppose the patient is having the bleeding, and if you want to shift the patient to the theatre, in the meantime, this mechanical procedures can be given. That is that a bimanual compression. Keep the right hand into the posterior vagina for the fornix and the left hand over the abdomen and compress for 5 minutes. Then itself it will get reduced. If it is a thin patient, means you can give the IOT compression also and feel the femur pulse whether it is felt or not. Next slide. Next slide. So this is the battery balloon. So the mechanical methods I have told. Suppose the bleeding is lesser, and if you see, so if you are going to refer to the from the primary health center to the other place, or from the hospital with no facilities to the other hospital where facilities are present, in that cases also you can go with this battery tamponade balloon. If it is not available, next slide you can go with a simple Foley's catheter. Foley's catheter can be introduced into the uterus, and the condom can be attached to that end, and you can fill maximum of 400 to 500 ml, and it can be kept and packed and it can be kept inside the uterus for 24 hours. This itself will make the contraction smooth. But depending on that, you have to see if it is not, the bleeding is not controlled, this Foley's will not be helpful, and you have to shift the patient to the theatre. So the bimanual compression, IOT compression, balloon tamponade, this can be tried. Next slide. Always everything should be done within 10 to 15 minutes. You cannot take your own time. If you want to go to the theatre, means it should be shifted within making the blood products arrangement of 30, within 30 minutes. This is the blood loss which I told, blood loss mild, moderate, severe. When it is severe blood loss, only the pale cyanosis collapse will come. Next slide. So the blood products, as I told, whatever is needed, the platelets and the whole blood, the plasma, FFP, platelet concentration, everything has to be kept ready. And depending on the loss which is now needed, we have to transfuse. Next slide. So these are all the blood component, which I told, whole blood, packed RBC. If the patient is going for a PPH, means immediately you should call for the help, and help one to blood bank and another to get the drugs, and one should inject the drugs, and all this things should be reserved. Whole blood and FFP, cryoprecipitate and platelets, depending on the amount. And if you are going to refer, you can collect the blood and also send the patient. Next slide. Next slide. So this is the uterine artery embolization. This facility is not available in many places. If at all not, this can also be done. In our place, most of the time we don't do this procedure. Whoever is having the facility with a good radiology department, they can go with this. Next slide. So the PPH is a life-saving procedure. Suppose if the patient's bleeding is not, and if you don't have the facility, and if you want to refer to the higher center, patient's bleeding is pulse query and BP query, means in that cases, you can refer the patient with this non-pneumatic anti-shock garment. In our Tamil Nadu, in even the primary health center, it is available. Here, the both the side, both the two of them should apply this garment. Both sides. This one will be around the ankle, and two will be around the knee. Three will be at the thigh. Four will be at the abdomen, and the five will be over the abdomen, and the six is the ball over the uterus. Both the side it has to be applied simultaneously and shift the patient. When you go to the hospital where the facilities are available, and when they want to go for the surgical procedure, means it can be removed. Once it is removed, it has to be packed like this pink. Like that, you should class, and it should be available in front of the labor ward. So we could not go and say this can be applied only for the pulse and the BP query patient. You should not allow for the pulse query and the BP query patient. If at all, if it happens, you can refer the patient with this non-pneumatic anti-shock garment and then remove it. It is only the temporary treatment which will allow the blood flow from down to go to the cardiac. That's all. From the lower part to the upper part of the body. Next slide. The surgical methods, if all this procedure is failing, means you can shift the patient from labor ward to the theatre. The square suture can be given, or the B-Lynch suture. This B-Lynch suture is from the lower segment, go around the fundus, and posteriorly from right side to the left side, and go around the fundus and come to the lower segment and put a stitch. This B-Lynch can be tried, and internal artery ligation can also be stepwise ligation. Uterine artery, ovarian artery, internal artery ligation can be tried. Oh, if everything is procedure is failed only, we have to go for the hysterectomy. Always try to preserve the uterus. Nowadays, the incidence of postpartum hysterectomy is reduced. Next slide. These are all the methods. So for the PPH, we are doing that mechanical methods, medical methods, and the surgical methods. This is the internal air catheterization, which if you are expert, nowadays all gynecologists are trained with this procedure. Next slide. The carbitocin, already I have told. Now, with the introductions of the carbitocin, the PPH incidence is reduced. Carbitocin can be maintained with the room temperature. No need for the fridge. And in our hospital, we are using this 100 milligram. It can be given IM or IV. Next slide. There are trials are there. The champion trials, which tells that the action is within 60 minutes and the drug is 100 microgram administered IV or IM immediately. So in this only drawback is there is no study to tell that it can be given repeatedly. It can be given only once, but it is very effective. Next slide. See, now these are all the champion trial which told where the carbitocin and oxytocin has been compared. The effect with carbitocin is good. Next slide. So this is the champion trial which I told it has been done with the multicentric 23 sites in the countries and proved that it is very, very effective and reduces the incidence of PPH. Next slide. Next slide. Then the tranexamic acid. Nowadays, it is also comes under the PPH bundle and 1 gram can be given and it reduces the bleeding. Next slide. This is the SR cannula. This cannula is available in all our primary health centers and the teaching hospital in the teaching hospitals in Tamil Nadu. This is the cannula which is formed by the Pinnacle, and this cannula is of two types. For vaginal delivery, you can use from the from below, and for LSCS, it can be used. Next slide. You put the cannula inside and connect to the suction apparatus. It will remove all the negative pressures and will reduce the PPH. Next slide. This is the way which cannula is connected and the bleeding is reduced. This is very useful and it can be, you can get it from Panikar also. In Kerala, it was introduced. Next slide. So the conclusion. So if the patient, any patient can go for the PPH, always have in mind, this patient, if it goes to end up in PPH means always for all patient, make at least 1 unit of blood available. Follow the answer, that is 10 units of syntocin immediately after delivery should be given. And the 4th stage of monitoring, the first stage, 10 centimeter dilatation, second stage delivery of the baby, third stage placenta delivery, fourth stage after the placenta is delivered for 1 hour, please monitor. Even the episiotomy wound, if you don't have the effects of the episiotomy not sutured, it will produce the hematoma. So the monitor for 1 hour and then only you have to move from that place. So identify the PPH earlier, and if you don't have facility, don't deny. Do the mechanical procedures or the medical management and refer the patient to the place where it is available, where all facilities are available. Don't refer to the place where the facilities are not available. Then document. You document it. 800 microgram of misoprostol is given. Carboprast injection is given. Oxytocin 20 units started. Whatever you have given, please document it. Then only if it is an high risk case, we will explain the patient. The normal patient going for PPH and mortality, it will be very difficult to explain to the attenders. Next slide. So always be careful. Now the latest by the way is the E-motive bundle, which is followed by everyone. This E-motive is the early detection of the postpartum hemorrhage, massage of the uterus, oxytocin drug, tranexamic acid, the IV fluids. For an anemic patient, you cannot push many IV fluids. And examinations of the genital tract evaluation, and accordingly we should treat. Next slide. I think all of you will be aware of this Taj Mahal. This is she died in the 14th delivery. For that only the building was built by Shah Jahan. But now it is not like that. You may be remembering of this incident in near Patna where the doctor committed suicide. So always documentation is very, very important. If the documentation is very clear, we can talk to the attenders and explain what has happened. So identify it. If you don't have the facility, refer it as early as possible. Next slide. Next slide. Say again. Next slide. I am Dr. Sampath Kumari from South, contesting for Foxy President. All of you, please vote for me. My aim will be from adolescent to menopause, for Padav, Parsat. And I request all make your friends also to vote for me. Thank you for this opportunity. Thank you.
Gayatri ma'am, your comments, ma'am. You're muted, ma'am. Gayatri, ma'am, you're muted, ma'am. Ma'am, you're muted. Gayatri, ma'am, we're not able to hear you. You're muted, ma'am. Can you unmute, ma'am? Yes, ma'am. You're muted, ma'am.
Anyway, I think again, if there is no doubt, Madhumita, you can give the vote of thanks. I thank all the president and secretaries. Formally, Madhumita will always, I should thank Madhumita, the MOC. Yes, Madhumita.
Thank you so much, ma'am. So coming to the end of this wonderful session, and first and foremost, I would like to thank all the delegates who joined in large numbers, and I would like to thank Dr. Sampath Kumari ma'am, who brings this excellent webinar series every 2 weeks for us, and Akola Obstetric and Gynecological Society President and Secretaries Dr. Rajesh Modi, Dr. Ankush Ajmera, and Dr. Mehvish Khan. Alwar Society, Dr. Abba Sapra and Dr. Charu Johari. Bagalpur Society, Dr. Biba Chaudhary and Dr. Vasha Sinha. Bidar Society, Dr. Uma Deshmukh and Dr. Savita Badigar. And Madurai Society, Dr. Gayatri and Dr. Sudha for active involvement from your societies. And I would also like to thank Gayatri ma'am once again for being an excellent chairperson for the talk, and my special gratitude to Dr. Nandita Thakur for moderating the panel, and also our expert Dr. Richa Gupta, and our esteemed panelists Dr. Jyotsna, Dr. Nandini, Dr. Mangala, Dr. Priya Kannappan, Dr. Vijay Lakshmi, Dr. Gomati, Dr. Sadhana Devi, Dr. Preeti Javanwal, and Dr. Divya for your valuable inputs in making the panel very informative and very practical. And I also thank Sahiti, Priya, and the entire team for the excellent coordination of the webinar without any glitches. Thank you everyone once again.
Thank you, Madhumita. Thanks to all of you.
Thank you.
Thank you, Sampath madam.
Unmute.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am. Thank you.